if he is finishing with overjet because of his class 2, then the Bolton doesn't matter nearly as much. They're actually on their 7th revision of this plan. And immediately when I look and I go through my checklist evaluating their case, I notice that the bite is not set properly. The patient has shifted their jaw further anteriorly, and so it looks like they're hitting edge to edge. So the attachment is fine. Is the number of trays okay? Well, if you look at how many trays we have here, everything's happening in about 26 aligners. I would hazard to say that 26 aligners is like, there's quite a bit of movement that's gonna have to happen in this case. And it's showing a bite jump, which we'll talk about that in a moment. Now, the first case that we're gonna be going through, and these are both cases now that are completed, is a patient who's in his early 40s. Now, when you look at where his teeth are positioned right now, his main concern when he comes in is his missing tooth. He previously had a flipper for it, but he's lost the flipper and the space has started to close. And so his goals of treatment are to create space to put something back there. And he's also been talked to in his hygiene appointments about how much he's grinding and wearing his teeth. Now, this makes sense because when we look at his facial balance, whether it's the Ceph or just looking at his face, he is a very hypodivergent patient. So he's very strong musculature with a very short lower facial third. He's got dished in profile with a more prominent nose and a more prominent chin. Now we look at the lower arch and we can see that we have a tooth that's blocked out, but other than that, there's not a whole lot of crowding going on. And so when we evaluate this, I don't think we need to extract a tooth because we do, fortunately, have minimal crowding and we can make things fit either with IPR or just from evaluating his gingiva. When you look at these lower incisors, the gingiva is nice and thick, so I'm not too worried about gingival recession just based off of the bone in the gingiva. Again, I'm not needing to take a CBCT to tell you this. In many cases, we do take a lot of CBCTs to evaluate things, but I don't need that to tell you that right now you look at this tissue and he will be able to handle expansion without a high risk of recession. So we know we can bring that tooth into position. On his upper arch, we know that we're going to have to create more space for the lateral incisor. We know that he's wearing and damaging his teeth, and so we have a conversation with him about restorative treatment. And is this something that we can do to build back up the missing tooth structure that he's ground and worn down? Because that's the thing, is that the majority of the cases where I'm talking to patients, we're not talking about the aesthetics. We're talking about the damage that's happening to the teeth from bruxism and wear, from the malocclusion. We're talking about being able to open up spaces for restorative with implants or bridges or whatever it's going to be. And so because of that, it's just something I want you to recognize that if we're only ever talking to patients about aesthetics, then this isn't most patients' top priorities. Now, patients, of course, care about that and want to improve their aesthetics. But if we talk to them about the functional issues that are going on, that is what patients really care about. Okay, so we go ahead and we submit this case and get a ClinCheck back. Now, the ClinCheck that we're going to get back, we're going to walk through all the adjustments that I would look to make on it. But I'll be honest in saying this is a pretty ugly ClinCheck you're going to see. And we're going to make the modifications and go through everything together. So for those who have heard me speak before, you'll know that I like to approach things the same way every single time. That essentially we have a checklist that we're reviewing where we go through and we evaluate if we need to make alterations or changes one line at a time. Just like how a pilot has a pre-flight checklist they go through to make sure that they don't crash, which is very timely with what's in the news right now in Toronto. So I'll go through essentially my checklist here as to all the things that we're going to be evaluating. Okay, so for those who are in Clearly Select, you likely know this already. For those who aren't, you'll learn in a second here that we use a program called Text Expander. And Text Expander allows me to have essentially a snippet or essentially a copy and paste of something that can go into another location. So I'm just gonna go ahead and type into the comment section right here, review-cs-short. And this is a series of, again, decisions about is there things that we need to evaluate and make adjustments on that we can go through line by line. So the first thing I'm going to evaluate is the basics. So the first thing we'll look at is, was there any tech comments that were relevant? Is there anything they're telling us right now that we should evaluate and look to change? So let's go to plan number 1 and let's evaluate. So essentially they're telling us they gave us Pontics, there's root control, there's smart force attachments. That's about it. So no, there's nothing really relevant. The next thing we're going to look at is whether the bite is set properly. So we click to our photos, we check things out, look to our front view. yes, the bite is set properly. Look to our side view. Is the bite set properly? Yeah, it essentially matches what you see here. Now, why this is so important is actually because I had a ClinCheck that I was working up with a doctor, I don't know, a week ago, and the doctor has spent a lot of time working on this. They're actually on their 7th revision of this plan. And immediately when I look and I go through my checklist evaluating their case, I notice that the bite is not set properly. The patient has shifted their jaw further anteriorly, and so it looks like they're hitting edge to edge, and there's lots of IPR planned on the lower incisors to back things up. When you look at the photos, you can see the patient is actually biting in a class 2 occlusion. And so because of that, the entire case has been set up completely wrong. The first thing that I do then when adjusting this is literally just write to the technician. I remove all of the comments that I was just going to go through. So I spend 10 seconds on this case. The bite is wrong. I literally type back to the technician, please adjust this case, set the bite as per the photos. All of that work, that hour and a half to 2 hours of setting it up, is completely eliminated and erased and would have been avoided if the bite was set properly. So this is something super minor, but also just very important. So is the bite set properly? Yes. Make sure you look at it from the same angle, but the occlusion is the same. Okay, so what's coming next? 4 passive aligners. So at the end of each batch of aligners, we're always going to recommend having 4 aligners. Back in the day, we used to have 5, but 4 aligners that just do nothing. They literally are there just to hold the patient over while we get more aligners. And the way that it shows up is if you hover here, it's going to say passive aligners on the top arch. It'll say active on the bottom, but if you actually drag through, you won't see any movements occurring. This is just a nuance with the software that they always show one arch as having some movements, but essentially those are passive aligners that aren't doing anything. The next thing, the final canine and molar position. So where are we positioned at the very beginning of this plan? And where are we positioned at the very end of this plan? Right, so we're starting off in a class 1 molar on our right side. At the end, we're still in a class 1 molar, so that's good. Our canine on the right starts off in a class 2 canine due to the crowding, but it's going to finish in a class 1. I'm okay with that. I like that. It looks good. On our left side, when we evaluate, the patient starts off in a class 2 on the molar. At the end of treatment, they're finishing in a class 1. Now, this is something that I actually would like to accomplish. We'll evaluate this a little bit more in detail as we get to the elastic section here. I would like to accomplish this. It's just the way that they're going to show it being accomplished is not realistic. But ideally, I would like to correct the anterior posterior for this patient by that small amount of probably about 3 to 4 millimeters. But I'll show you why I want to accomplish it in just a moment. But am I happy if we were to finish with this patient biting in a class 1 molar canine on the left? Yes, I would be happy. So I'm going to remove that line. Next, is this a growing patient? If yes, then we would always fix to class 1. If it's a non-growing patient, then we may want to consider what's realistic. Now, what's nice about this case that you guys are going to see from both of these is it's really easy to cherry pick cases where you just see everything perfect. But my goal is actually to set up or to show you cases here where there's things that aren't perfect, where it's not beautifully going to work out, where the patient is not fully compliant, or whether I miss something or could do something better, or circumstances happen outside of my control. And so you're going to notice here that things aren't all going to be 100% spot on at the end of treatment. And I'll show you why. And we'll talk about what we could or could not do about that, realistically speaking. But the goal of what we're setting up here is that we would like for this patient to finish in an ideal position. And let's make sure you guys can see the notes here. Okay, so they are non-growing, but the amount of bite correction here is fairly minimal. So is it realistic that he could finish in class 1? Yeah, it is. Okay, are there any unmovable teeth? Is there any implants? No. Next, curve of Spee. And I just want to point one thing out right now, which is you'll notice that I don't have the attachments toggled on. Because in reality right now, I only care about checking out where the position of the teeth, because the attachment section comes later. So it doesn't matter to me that the attachments are not toggled on. I intentionally would recommend that you have them off. Well, let's take a look. So where we first start off, you can see that the bite is flat, but the lower incisors do sit a little bit higher than the premolar teeth and the lower 6s. But when you evaluate how much wear is on these teeth, there's quite a bit. Now, this depends on the patient's goals of whether we want to intrude the teeth to line up the gingival margins on the bottom so that they can be built up as well. Because again, just check out how much wear and damage has happened on these teeth. Realistically, if you were to measure this and compare it to someone who hasn't had any wear, I would say that 50% of the tooth structure is currently missing. And so my strong recommendation to this patient is that we should really look at doing some buildups and either doing crowns or doing composite to give structure back so that he's not going to continue grinding his teeth down further and further. So that'd be my strong recommendation, but patients aren't always going to necessarily listen to those recommendations. But if we look then from our initial position to our final position, have we intruded the lower incisors to correct the curve of Spee? Well, yes, the lower incisors procline and they intrude. So it's corrected, but we may want to consider over-treating, like you see here. Because if we can over-treat then, or even just treat more, it will allow us to push down those lower incisors and build up restorative. So I'm going to leave a note here and we'll evaluate that more. And I'll show on the final ClinCheck just how you could make modifications like that happen. The next thing we're going to look at is the final position. So have we created proper arch form? So first of all, are the upper sixes derotated and parallel to one another? They are. You can see how the buccal surface, there's some derotation of those teeth to create a better arch form and a better contact. So I'm happy with that. Do we need expansion of the premolars and do we get it? Well, we do need a little bit of arch development here, but there's nothing too significant in terms of the arch development we're looking at. So I don't think we need to adjust it to make it more or less. And I would say that the arch form at the end of treatment here does look ideal. Right? We have a nice rainbow-shaped arch. Next, let's look at the smile aesthetics for this patient. So what is the situation for the midlines? And what is the situation going to be for cants or other restorative treatment? So when we look at the patient's facial balance, you'll notice that his midline of his nose and the midline of his teeth, it's pretty close. I would even hazard to say that his midline of his teeth compared to his nose, that his teeth are slightly positioned more towards his right. See if this will actually behave now. If we measure down from his nose and then where his teeth are, slightly move to his right. Now here's the consideration that I want you to have. If we go ahead and open up this space for an implant, I want you just to imagine right now that you put a spring between the canine and his central incisor. We're not even talking like orthodontics or anything along those lines. You literally just put a spring between these two teeth to open up space. What's going to happen? Well, we have 5 teeth in the posterior segment here that we're pushing against. And in the anterior, we are pushing against some of the teeth on the other side, but realistically, we're pushing against maybe call it 1, 2, 3, 4, 5, if we were counting the kind of the arch curvature. And so as we push back and buckle the teeth in the second quadrant, the teeth are going to move. The teeth in quad 1 are also going to move towards the patient's right. So what's going to happen to his midline as we push to create space and open up room for that lateral incisor? His midline is going to deviate and move towards his right. And so that's a consideration that we really need to pay attention to. Because if we move his smile midline of his dentition towards his right, it's going to make it more asymmetrical. And now this case isn't designed with Smile Architect, which is Align software to put the patient's face into the ClinCheck. This predates that, but it would allow you to see that in the actual Smile Architect software as well, of where is his midline right now and where will it be at the end of treatment. Because as this ClinCheck currently looks, and we drag through it, his midline is going to move. We can click on the superimposition tool. Let's flip these so you can see. It's showing his midline moving right now, probably about 1 millimeter towards his right, which we don't want. So because of that, I'm going to keep this section listed here because I want to be cognizant that his smile arc could get worse if we're not intentional. Now, what's the next part? Well, cants. So does he have, at the beginning of treatment here, does he have any cants? Well, not that I would say he has like a skeletal cant, but you can see looking at the height of his central incisors, one of these central incisors is even more worn down than the other. So yes, the gingival margins are not even. So it's not so much that he has a cant, but I would say that, again, he would really benefit from building up these teeth and intruding them to make the gum lines even. So I'm just going to make myself a note here and say, okay, well, we want to focus on intrusion of these central incisors and the lateral to put the gingival margins even for restorative treatment. And that's something that he's on board for. He's on board for building up these teeth because he recognizes that there's challenges. Okay, the next section was the midline. Is adjustment needed? Is it shifting when it shouldn't be? And that's what we're going to keep here. So we probably can go ahead and get rid of the smile arc / gingival display. and focus here on, is there shifting when there shouldn't be for midline? All right, next section, Bolton and restorative. So the question, first of all, when we're evaluating the Bolton is, does the Bolton even matter? Now, what we mean by this is that a Bolton discrepancy is essentially a mismatch between the different arches. The teeth should fit together like a lid fitting on a box. But if the lid and the box don't fit together properly, then there's a mismatch. Now, the concern is not so much that the lid is too large for the box. The concern is always going to be, is the box too large for the lid? And think about it with Tupperware. If you try to put a lid on Tupperware where the lid is too small, it doesn't fit and it doesn't pop on properly. So if the bottom arch and the upper arch are the exact same size, they're going to hit edge to edge and they're going to have a posterior open bite. And so that's where we want to be aware, is there a Bolton discrepancy? So how do we tell if there's a Bolton? Well, the number one way is click on the Bolton analysis right here. And this tells us that we do have a Bolton discrepancy. We have a Bolton discrepancy of 2.11 millimeters in the lower 3 to 3 region. Now this is assuming, let me zoom in on this. It's assuming though that this lateral incisor is being put back into position with it being 5.76 millimeters in width. So it's saying, yes, there's a Bolton if you have 5.76 millimeters for that tooth that you're going to put back. Because if we were to theoretically just close this space between the central and the canine, of course, like this patient would end up biting edge to edge on their anterior teeth because we're removing essentially 5 millimeters of tooth structure on the top. So if we pull back the maxillary arch further and we straighten the lowers, it makes sense that this patient would bite edge to edge. But the Bolton evaluation of why it matters has to do with, is the patient class 2? Because if you have a patient who comes in who has an 8 millimeter overjet, and you look at your Bolton analysis, you say, wow, those lower incisors are bigger than they should be. I'm going to do IPR on the lower incisors to fix this Bolton issue. But the patient has a 9 millimeter overjet. They have micrognathia and they literally have no mandible. If you go in and do a bunch of IPR on the lower, all you're going to do is make that overjet worse, because Bolton really only matters if the patient is biting in a class 1 at the end of treatment or a class 3. It does not have relevance if it is not a class 1 or class 3, unless you're considering the size of the teeth for smile aesthetics. So in his case, when we evaluate, does Bolton matter? Well, yes and no. It matters if he was class 1 everywhere at the beginning of treatment, then yes, the small size of these lateral incisors will cause us issues. But no, from the sense that if he is finishing with overjet because of his class 2, then the Bolton doesn't matter nearly as much, right? Because his big class 2 is what is allowing him to have overjet. So in this situation here, Bolton is relevant, assuming he finishes in class 1. So let me just give a spoiler here in terms of what we're really looking at. If you are looking at a case and you're planning on leaving them class 2, or you're not sure if the patient will be compliant with wearing elastics to get into a class 1 position, then you should not consider doing IPR on the lower for Bolton reasons, if that's what you're planning to do, if you're looking to do IPR. But if this patient is trying to finish in an ideal class 1 position and there's a Bolton, then you either need to consider doing IPR in this initial batch of trays, or you need to consider doing IPR in the refinement batch. Okay, so once again, if there's a large overjet and they're in a class 2, and you're either not sure if the patient will be able to get to class 1, or you're not planning to fix it, then don't jump in and just say, hey, let's go ahead and fix all this Bolton by reducing the size of the lower incisors. Okay, so does Bolton matter? Well, maybe. Bolton might matter, right? It kind of depends based off of what we see going on here. So if we go ahead though and we click to our IPR, what you're going to notice is that the ClinCheck has been automatically planned with quite a bit of IPR on the lower. But again, we just said, if we're not planning on fixing the anterior posterior, or he doesn't wear his elastics well enough, then it doesn't really matter. So I'm going to leave this in place here saying, does Bolton matter? Class 1, class 3. I'm not likely to leave this IPR, but we'll come back to this a little bit later in the plan to see, okay, is this something we're going to leave or not? But yes, he is class 1 or 3, so Bolton is important. Is there a large overjet at the end of treatment? No, there's not. Look at the Bolton table. Evaluate, is it more than 2 millimeters? Yes. So either restorative or IPR would be needed if he's finishing class 1. Mandibular 3 to 3 is 2 millimeters or greater. It is. Are the upper lateral incisors 6.4 millimeters or less? Yes, they are. They're only 5.7 millimeters. So yes, they are small. So we want to consider building those teeth up instead of doing the IPR on the lower. So the considerations then between IPR and restorative would be, does he have good gingival biotype? So can he handle the expansion on the lower? Yes, we looked at that already. So we're not worried about fragile tissues. Are we worried that he's going to end up with a lot of black triangles? Well, he may have some black triangles. Let's go to before the IPR happens. You can see that there may be some black triangles that open up if we don't do IPR. But is this something we're super worried about? No, I don't think that his black triangles are significant enough right now that I would say we should do IPR for sure. Instead, I think we just evaluate. The next thing we'd look at would say, are there uneven or worn gingival edges? Well, yeah, there is. So that leads us to say that gingival leveling with potential buildups to make the lateral incisors bigger would be a better option to balance his smile aesthetics. So yes, we would benefit from leveling the gingiva. Is there adequate overjet at the end of treatment? At least 2.5 millimeters or 2 to 2.5 millimeters. We can click on our overjet here to see that yes, at the end of his treatment, he would have enough, but that's because we're doing IPR on the lower. So we want to keep this line and come back to this. If no, consider upper IPR spaces or restorative spaces. The next consideration would be, if we are planning IPR, is it all happening at the same aligner number? So my preference is always going to be, if we were doing IPR, that it's going to happen at the same time. Here we can see that IPR is happening in 2 different time points. At aligner number 1, but then also at aligner number 15. Now, even if you look at aligner number 15, which is going to be the next consideration, it will ask, are the contacts derotated enough to access the contact? Which they're actually pretty good. But I would prefer to actually do all of this IPR at the exact same time and not do IPR at aligner number 1 and IPR at number 15. Why not just delay the IPR that's happening at 1? So clinically, I don't need to be there doing IPR once and then again. So again, this is just the evaluation of, is the IPR occurring at the same time? Do we want to adjust it? And are the contacts all derotated and accessible for us to do the IPR in? Yes. Okay.
Stephen, just giving
if
you
leaving space for restorative, there's a specific instructions we could leave for the technicians, which would say to leave ideal residual spacing for prepless restorative around the upper lateral incisors and lingually incline them 3 degrees. I'm just going to show you how you can actually take control of this and do it yourself when I make some modifications. Okay, same thing in this example, I've just left the text instructions that if you needed to have the contacts derotated more, you could just leave this statement in for the technicians saying complete IPR once contacts are nearly derotated, ensure all IPR occurs at the same stage. Okay, so this takes us through the IPR component. Again, we're going to be looking to remove the IPR and instead creating spaces around the lateral incisor, building up the gingival or intruding the teeth so the gingival margins are even, and then building up the incisal edges. Okay, next consideration. So we're finally getting through just the basics in terms of the final positioning of the teeth. And maybe actually at this point, I will just show you something. This is fortunately a bit of a spoiler because I'm not able to actually modify that plan. Because once you've created the plan and you move to your next ClinCheck, it's not going to allow me to actually change anything. So here you're going to see this is actually our final result. So spoiler, that's what it's going to look like when all is said and done. But I just want to show you how to take control over movements of the teeth, which normally we would be doing on that actual ClinCheck with the teeth in their current positions. So if you want to grab the tooth and level the gingival margins, it's easy to do. Just grab the tooth, drag up, and you can position it wherever you want. So if we felt that the gingival margins needed to be adjusted, and spoiler, you're going to see here that he did not choose to restore his lower incisors, but ideally we would have them positioned so they're even with the lower canines, and then restorative could occur. So this is how I would take control myself, just to physically move those teeth into the right position. And if you wanted to create more space around a lateral incisor, well, you could go ahead and position the tooth so it's slightly lingually inclined. That's all I was asking the technician to do there, was just put 3 degrees. You can see right here. You can actually even type this in, 3 degrees of lingual crown torque. And that would position the lower lateral incisor slightly more lingually inclined, so that if you were building up just the laterals, for example, then you could go ahead and do a prepless veneer because you've increased the space available for the buccal thickness. And this is a protocol that I learned from Terry Coddington, which is really great for prepless veneer situations. So those are the methods that you can use to move the teeth into the proper position to level the gingival margins and to give yourself a little bit more space for restorative if you were just focused on 2 teeth. Okay, so this would cover the section. So by intruding those teeth, you're correcting the cant. What I've just shown you here was leveling the curve of Spee. We'll talk about the midline still in a moment. The Bolton, what we would be able to do is we would be able to create additional space around the teeth just by clicking those arrows and increasing the space by hitting the plus to give ourselves more room around the laterals as needed. Again, this is obviously showing the finalized restored position, but this is how you could create space around your upper lateral incisors so that you're getting enough space to make the teeth at least 6.4 millimeters wide. In the end, you can see here that the laterals were made to be 6.8, 6.5. So they were made to be more proportional to what they originally were supposed to be. Okay, so those are just examples of how you would be able to make those changes. Again, I wish that I could do it on this actual ClinCheck, but the way that Invisalign has changed the way that you can do practice cases, you can't make modifications to this original ClinCheck number 1. So you'll have to use your imagination with just how you'd click on those and move those into the proper position using those 3D controls. I'm just going to do this and discard, make sure I don't lose all of my comments, but I'm going to discard that ClinCheck just so then I can keep modifying. Okay,
Steven,
let's go back to treatment plan number 1.
minutes.
And now what I want to evaluate is, are there movements that are occurring on these teeth that are inefficient? Are the teeth moving one direction and then moving back an opposite direction? So we just click, drag through the ClinCheck and see, do teeth move one way and then move back another way? Yeah, I mean, on the central incisors, it does a little bit. The teeth move buccally and towards 1. I think it's okay because the movement isn't moving like one direction and then back the other direction. So I wouldn't say that we need to adjust the movement of those teeth. I think we're all right. Okay, so no round tripping we need to worry about. Is there any extrusion that's occurring to any significant degree? I guess this lower canine does have some extrusion occurring. And you'll see this in the next plan that if we want to make sure that we have really consistent movements around this tooth, if we create some space, I guess I shouldn't have exited my modified plan, but if you want to create some space around this tooth, the best thing, or you want to create consistent movement, the best thing you could actually do is to create a little bit of room around that tooth. And you'll see this on the next case, so I'm not going to talk about it too much, but creating space around that tooth will ensure a more consistent plan because friction is our enemy. We really don't want friction to occur. But other than that, there's no major extrusion occurring. So I'm not worried about any other teeth moving. But yes, this tooth, we need to be more cognizant that the extrusion movement is harder to do. So is the staging good or bad? Well, I would say that the staging of how this tooth is extruding is okay. You can see how right now, if we tried to extrude this tooth, you'd be hitting it against the canine. Instead, some space is created around it, but then before the tooth can finish extruding, it hits against the neighboring tooth and there's going to be friction. So all of this extrusion from here at stage 11 onwards is not as likely to occur because that space that we created is now gone and it's hitting against the neighboring tooth. Now, yes, we are doing IPR between the teeth, but the same thing's happening on the other side of the tooth too, that there's some friction. So we'll put a pin in this and we'll evaluate it on the next case more, but that's just what I want you to pay attention to is that anytime you have a hard movement, I want you to pay attention to friction. If the teeth are hitting and moving through each other, it increases the likelihood that things will not track. The next consideration when we have a tooth like this that's out of the arch and needs extrusion is, would it benefit from using elastics to extrude? Now, realistically, no, we're not needing elastics here. Is there adequate space around the tooth? We just kind of described how it was okay. If I was to give instructions to the technicians, I would say, please give 0. Maybe even 2 millimeters of space around the lower right 4 and do not close it. We keep that space. Okay, now we finally are getting at the point where we can toggle on the attachments. So is this a good attachment? Now this is an optimized extrusion attachment or an optimized deep bite attachment. It's going to be one of the two. They're kind of the same shape. So is this attachment the right attachment for the movement? Well, it's actually not terrible because there's a pushing surface that's coming from the gingival aspect. So the pushing force is going to be hitting from the lower upwards, and the area that we are pushing against is going to be this gingival aspect of the attachment. So this is actually all right. Now, in many cases, I will change this out for a conventional attachment, But if you chose to leave this particular attachment on it, it's not bad. Now, if the attachment was this rotational attachment on the side, this would not be good. I would definitely want to change that attachment because it's not oriented in the direction that we want. It's oriented more in a rotational movement. So we definitely want to make sure that the attachment, if we're extruding the tooth, is being pushed against from the gingival surface vertically in the direction of the extrusion. So the attachment is fine. Is the number of trays okay? Well, if you look at how many trays we have here, everything's happening in about 26 aligners. I would hazard to say that 26 aligners is like, there's quite a bit of movement that's gonna have to happen in this case. And it's showing a bite jump, which we'll talk about that in a moment. But I would say that 26 aligners is maybe not enough trays for this to actually occur. Because the other consideration is that this canine or this premolar tooth does have some root movement that's happening also. So I think we may want to go ahead and consider increasing the number of trays, maybe if we're doing weekly, to 40 active aligners and 4 passive. We'll say nearly passive for 44 total aligners. Okay, the next consideration, a pontic. So if we click on our pontic tool, we can see that there is a pontic that's going into position right off the bat. Now, is this pontic aesthetic? Is it good? Is it bad? Well, let's go through our list. So do all pontic areas that need a pontic have them? Well, he would ideally like to have a pontic, and I believe we do use one. Now, is it the right size? Well, to start off with, yes. Is it growing properly as the space opens? Yes. So am I happy with that? Well, yes, it's not the prettiest of pontics. So you could ask the technicians to make it symmetrical to the opposing tooth, the contralateral tooth here, by saying use the contralateral tooth as a mirror image. But to be honest with you, I wouldn't necessarily say that that opposite side pontic is the most beautiful, or the opposite side lateral is the most beautiful tooth. So for that reason, I think it's probably fine for us to use this current pontic as designed and not worry about changing that. Okay, next, is there any eruption compensation needed? Are teeth erupting? Nope. Cool. So after all of that, it's finally taken us to the point now where we're onto the attachments. And again, always remember that when we're evaluating this case, I'm making these decisions very, very quickly, one at a time, just like you guys can. Right now, we're talking about every single decision. So this is taking us over an hour just to do one case. But I want you to recognize that when you are practicing this, it's ensuring that you don't miss anything. And it might seem like it's overkill right now, but it's setting up these systems that allow you to take on hard cases and have a very easy, straightforward one decision at a time, rather than needing to try and look at an entire ClinCheck and see, is it good or is it bad? Okay, so the next consideration is, are there going to be attachments that are occurring on crowns or on teeth that just won't bond properly? And if we look to his lower sixes, yeah, those teeth are not going to bond well. His upper six is not going to bond great. On his left side, same thing as lower canine here is not good, or lower first molar, I should say. And then we want to be cognizant of where we place any attachments on his upper first molar, because anywhere more on the distal aspect of the tooth, and it's just going to fall off. So are there any attachments right now that we need to remove off of crowns? No, we're fine. In terms of the actual attachment placements though, now we're going to evaluate, do we need attachments that are used for retention? Well, yes, we will need some. So first of all, do we have deep bite? And are we intruding our lower incisors? The answer to that is yes. So yes, we will need to place attachments that will help facilitate the intrusion of our lower incisors, especially if we're planning to intrude those teeth down further so that we can build them up restoratively. And same thing on our upper. So we will need attachments for our deep bite. Now I've shown you how you can modify that plan, but what I'll do is I'm just going to jump ahead and show you where some of these attachments are placed. So what we're doing is the deep bite attachments we want to be using is going to be this 3 millimeter to 4 millimeter horizontal attachments, because these are going to allow the trays to lock into place on the gingival aspect. So a good rule of thumb is you can just straight up remember, anytime that you are looking to intrude anterior teeth, you need to have a nice 3 to 4 millimeter horizontal attachment on your premolars, and ideally your first molar, but we can't because of the fillings. But that's going to allow the trays to lock into place. So these would be the attachment considerations I would have on our lower for our deep bite correction. On our upper, and again, you'll see here, because wait till this intrudes, we're going to be intruding our maxillary teeth to line up the gingival margins for restorative. So because of that, we need to have horizontal attachments on our premolars. Or in this case here, we can use an optimized attachment because it's got a big, thick, juicy ledge on it that will help lock the tray in place. Now, a lot of you who've seen me speak before know that we will often do an aesthetic protocol with attachments so that nobody sees or notices that the patient's wearing aligners or has attachments on the teeth by placing the attachments onto the lingual side. And so that's where we have the lingual attachments. A good rule of thumb is just the kind of cheap and dirty way of doing this is literally we're just placing a 3mm attachment pulled out to its maximum thickness is the easiest way that you can place an attachment on the teeth. And then if a movement is needed, more in the mesial distal direction later, you can go ahead and place the attachment, a new one, onto the buccal at refinement. So that's the consideration with why these attachments went to the lingual. But again, the main takeaway I want you to have first is just, do we need attachments for the deep bite correction? Yes. Where do we place those? On our premolars, if we're intruding the anteriors, and ideally first molars. What type of attachment? A 3 to 4mm horizontal attachment. That's it. Are we expanding the arches? Maybe a teeny bit. We do have, and again, I'm jumping ahead. You'll see this in a second because I'm looking at the final plan, but let me go back to number 1. Are we expanding the arches? Yeah, a little bit. So because of that, do we need to have attachments ideally on the teeth that are expanding? Well, yes. So which teeth would benefit from having the attachments? Well, it would be our first molars and our second molars. Now, we can't necessarily place them everywhere on our first molars. We could have placed them more mesially, or you can go ahead and you can leave them off knowing that just maybe some of the expansion you planned isn't going to fully express, and that's okay. But if you have expansion, you need to have the right attachments to facilitate that expansion. So that would be horizontal attachments on whichever teeth are expanding, unless you can't get them on. So again, let me go back to treatment plan 1. Okay, so expansion on the premolars, so they need to have some type of attachment on them, ideally a horizontal attachment for that to happen. And on our 7s, we need the same thing. Do our upper lateral incisors need attachments on them? Well, yes, because they're very small. So anytime you have a small lateral with any movement happening, needs an attachment. And then the last consideration is root rotations and difficult movements. Now, the most difficult movement that we're really looking at is that lower premolar. Now, you could leave this attachment, but if we want to have a more consistent plan, the way to do it is to change out the attachment for a thicker, juicier horizontal attachment. And that's going to be more consistent in making the movement occur. And also, if it doesn't fully express, you can leave on this attachment. You don't have to take it off, because I'll show you by jumping ahead here. At refinement, you'll notice that this attachment is still a lot thicker than what a conventional attachment might be. So look at all these conventional attachments and how thick they are. And then if we go look at our 1 optimized attachment, where was our 1 optimized? Right here on our premolar. Actually, it fell off. We didn't have it. So we had to change it for a conventional anyways. But the key point is that you can leave conventional attachments on at refinement. And if the movement doesn't fully happen, then that's okay. You can just go ahead and do more movement using the exact same attachments. Okay, so this takes us now through to the final sections, which is elastics. Do we need elastics in this initial plan? Let's talk a little bit about a bite jump. So what is this movement that's happening at the very end of the plan? That movement that shows the jaw jumping forward is called a bite jump. A bite jump only happens because of changes in growth or repositioning of the condyle in a patient with TMD. So this patient does not have TMD, and obviously he's not growing. So the bite jump, realistically speaking, when you see this in a ClinCheck, will at maximum be in a non-growing patient, maximum would be 2 millimeters, and it could be 0. So if we look at our grid here, and this might be hard to see, I don't know how well it shows up, we evaluate, well, how many millimeters forward is it showing a repositioning of the jaw? So from here, we're going 1, 2, 2.5 millimeters. Each grid is worth 1 millimeter. So we're getting an anterior repositioning of the mandible by 2.5 millimeters. Well, is this patient here likely to have growth that we can modify of 2.5 millimeters? No. Are they likely to have anterior posterior repositioning from TMD where the condyle was forced backwards, and as we expand and develop the arches, the jaw will reposition? I'll give you a spoiler here. No, it doesn't happen. That doesn't happen. So because we see that bite jump, showing him going to a class 1, what it realistically means is that this jump, and I'm kind of jumping ahead here because this is the section we're looking at, how much AP correction is occurring, It is more than 2 millimeters. So realistically, this movement is not realistically going to occur. So let me just cross some things off the list. Do we need vertical elastics for anything? No. Do we need crossbite elastics? No. Do we need elastics for anterior posterior? Well, yeah, it's showing an anterior posterior change. How much is it? It's more than 2 millimeters. So do we need to consider a different technique for how we would correct to a class 1? Well, yes, we would. And then the last thing will be is, are they in the proper location? So what is the other technique that we can do? We can do what's called sequential distalization, where we back the teeth up one tooth at a time. So I want you to look at how now in this new plan, we've removed the bite jump. There's not going to be any jumping occurring. Instead, just look at how the second molar moves back until it reaches class 1. Now the first molar, second premolar, first premolar, and then the canine. So these teeth are moving back one tooth at a time. Now the reality is that this is not happening. This is really key. This is not happening from the aligners alone. This is fully happening from the aligners with the elastics. If this patient right now, if you plan this case and you showed all these teeth moving backwards and he doesn't wear his elastics, spoiler alert, if he does not wear his elastics, he will not end up having any anterior posterior correction on the left side. It will not happen. And that's exactly what you're going to see here. So let's take a look. This is what we've planned. Sequential distalization. The teeth move one at a time. It backs up. In the anteriors, we intrude those teeth. We've changed out the attachments to help support the deep bite correction. We leave some vertical space on the lowers to build up some of these teeth. We could have intruded a lot more, to be honest, and nowadays I would. And the last thing is we actually have overdone the intrusion because we know that whatever we plan, we won't fully get. We never get as much intrusion as we ask for. But we do want to leave this in an open bite because we need to build it up. Okay, so let's go ahead and take a look at how things look after this patient's first round of aligners. So this is where he first starts off, and this is where he's at after his first batch. So you can see really good intrusion of those central incisors, good intrusion of the lowers. The premolar has extruded nicely. The incisal margins aren't the most even on these lowers, but it's definitely flattened his curve of Spee. And if you didn't know better, you'd think we suck at what we're doing because we created an open bite in the anterior, but that doesn't matter. That's fine because we're planning restorative to build this up. We've created a little bit more space here. It's not maybe tracked as nicely as we want, but there is more room compared to where we first started. But here's the thing I want you to look at. He is not biting in any better position, class 2 on his left, compared to where we first started. Why is that? Well, he didn't wear his elastics. Here we were using a button cutout to a slit, but because he never wore them, and in a case like this, he'd have to wear them very consistently for this to be successful. Because he did not wear them, well then we don't expect to see any anterior posterior correction. And so this is where a very honest conversation comes in. Because we need to tell him, hey, if you're not planning on doing your elastics, then you're not going to finish in an ideal position. Because let me point out one other thing that's crucial. Remember we talked earlier in this case about how the midlines come into play? So if we're looking at this patient's, the midline, right, we knew before that if we go ahead and we just create space by pushing back the teeth slightly and pushing forward the front teeth, you put the spring between those teeth. Oh, let me get the top, sorry. What's going to happen, come on, is the midline is going to move, right? Just again, remember, imagine that you literally just, and even ignore all the attachments here, you just go ahead and you place a spring between the canine and the central incisor. That's it. That spring is going to push the anterior teeth towards quad 2, and it's going to push slightly back on the canines, but there's way more teeth on this side with bigger roots. So ultimately the midline is going to move more towards quad 1. That's why when we decided, okay, let's go ahead and do sequential distalization, by sequentially distalizing the teeth and moving them back one tooth at a time, the elastics are what's helping pull back the anterior teeth. The elastics are what's making this movement happen differently so that the midline doesn't change. That would be the goal. But what are you going to see here? I love this smiling picture. It's the best. I think the assistant's could have definitely retaken that one for him. But if you look at his midline. His midline has moved over. It's moved towards quad 1 from where it was previously. And so that's the consideration in the conversation with this patient is to say to him, look, because you haven't worn your elastics, which we really hit home on how important those are, because you haven't done that, your midline has shifted. And we can restore these teeth, but it's not going to allow your midline of your face to line up with the midline of your teeth. Are you committed to doing this component? And the honest answer that he's giving is no, I'm not. And so be it. We can only do what we can do. So he doesn't commit to wearing his elastics. And so what we're going to do on our next plan is, and puts my IPR in here, here's where he's at. He's still biting in quite a significant class 2. We're adding a little bit of IPR in because we want to actually help try and correct his overjet a little bit more now. We're intruding the lower lateral incisor because that was the worst worn tooth. And he, when we talked to him, would like to consider building this tooth up. So that's why we're intruding the lower incisor here. And we're doing some expansion. So we're not doing too much in the sense of we're not sequentially distalizing these teeth or anything, but there was a little space still behind this canine. But we're closing that space and we're expanding the arch a little bit. We're uprighting this central incisor and we're doing a bit more fine detailing of the gingival margins. So that's essentially our movements that we've planned, and this is what we accomplished. So did we accomplish the intrusion of our lower incisor? Yeah, looks great. Did we fix the slight canting that's going on with our centrals? Yeah, we have. Did we open the space slightly more for our lateral incisor for the restorative with the implant? Yes. Again, is he still biting in a class 2 from where he first started to where we're at? Yes, he's still biting in a class 2. And is his midline deviated towards his right? Yes, yes it is. So these are the main considerations. The things I want you to take away from this case is that there's nothing that we've really come across that's that complicated right now. Right? We put on attachments to help with intrusion of deep bite on the lowers. We put attachments on to help with a little bit of expansion on the uppers. We overdid the intrusion in the anterior to level the gum lines. We tried to do sequential distalization, but we may as well have done nothing at all because it didn't make one minute difference in this case because he didn't wear his elastics. So in the end, the key considerations to take away is just that having the right attachments facilitates the right movements, and that he was compliant wearing his liners, so that was fortunate that everything still tracked properly and we're able to create the space, but his midline will shift because we're cracking open that space evenly across both sides. So all we're doing at this point now is holding him while he gets other work done. So in tray number 20, or treatment plan number 20, so little tweaks we're making, but we pretty much at this point can just hold all of the teeth movements and just work on the opposing arch. So we didn't do anything on the upper. We're just working a little bit on the lower. Now here's something interesting for you guys. I get asked all the time, well, what happens if you intrude a tooth and then you decide that you want to undo that movement? Well, he changes his mind in the meantime about doing the restorative. And so all we do is we allow this tooth to have controlled relapse. Right? We pushed it down and we intruded it. Well, now if he doesn't want to do that restorative, all we're doing is essentially just letting that tooth relapse and extrude. So we don't have an attachment on the tooth. There's nothing going on there. We're literally just letting it relapse. Because theoretically, if you just cut your aligner and had nothing covering this tooth, that tooth would extrude on its own. So we're just helping guide it with the tray. That's it. So that's all that's happening on this batch is just some minor adjustments while he's getting his implant placed and the restorative is getting all prepped. So let's go back to aligner. So his teeth that he now has on his plan here, right? So he's gone ahead and he had the implant placed and they did some grafting, bone grafting, which has changed the tissue in this area of how it is attaching to the attached gingiva. You can see that this lateral incisor has extruded and now it's even. And again, no attachment was needed on that tooth. We have good spacing for our restorative. He goes ahead and gets all the restorative done. This was just before his lateral incisor crown implant was uncovered, and then his crown goes in. And so this is what it looks like once the restorative is complete. So when we look to his aesthetics, you'll notice again, deviation of that midline. He's biting in a class 2 situation on his canines on that one side. On the other side, of course, because he started in class 1, he still finished in class 1. Nothing changed in that way. The overjet is okay. It is a little bit more significant because he's a class 2. And that's just the reality of completing treatment, right? We treat adults realistically. We treat growing patients idealistically. His lower incisors, we weren't able to build those up because that's not what he wanted to do. But you can see how we've intruded those teeth and helped correct the curve of Spee and how much the vertical has changed from where he first started as well. So again, I want you to take away the details of this case because you might not feel comfortable treating the whole thing, but I want you to understand that this is something that's definitely doable for general practitioners. And it's not necessarily even that complicated as long as you have strategies for how you approach it. And so those are the key things I want you to recognize from it is have the right attachments, even if we don't have everything perfectly designed, like there was things we did not do as well as we could have, but yet the case is still successful because, and even though we didn't have everything ideally set up, we pretty much only had one major batch of trays on him to accomplish the majority of these movements. The other thing that we always want to do when we're doing these webinars is just give the opportunity for doctors to know more about Clearly Select. Now, you heard about Clearly Aligned there. I don't know if the audio was coming through. It was giving us challenges before. But the thing with Clearly Select is that Clearly Select is a group that we've created that now has over 250 dentists in it who are motivated to grow in their aligner capabilities. Because you can get this information from me and have a webinar, but to actually implement this in your office is a completely different story. For example, I just spent probably 5 hours today working on consult forms and explaining how we organize and operate our consults, our financial presentation, our forms that keep patients compliant, and how we transfer cases, how we finish cases, just how we operate in our office. And so being able to give the exact systems that we use in an office doing 400 plus cases a year is so valuable. And that's the goal of Clearly Select, is not just to have, here's a lecture, go ahead and do it. It's to give you the rest of the information. It's to put together a community so you have other people who are working through the same challenges that you are and implementing the same things. It's to create supports both in the systems and operations. It's to give accountability to ensure that doctors actually are growing with their case volume. Those doctors who join Clearly Select will actually do 10 ClinCheck reviews from scratch for cases that otherwise might be outside your skill set that you would be referring. And so from a financial perspective, not only are you getting discounts that are in line with what the best in the industry has to offer, so realistically, most doctors are saving $30,000 on their lab fees, but you're also being able to take on cases that you otherwise wouldn't feel comfortable with us keeping you in the guardrails and making sure that you're staying safe. We have specific events coming up. For example, in March is our Clearly Illuminate conference in Palm Springs. And so you can't come to this event unless you're a member of Clearly Select. We're not even like, you could pay us anything, and it's only for the doctors who are in Clearly Select who can attend this conference. And so I think we have 12 different speakers talking on all different areas of orthodontics. And so our goal is to create something that's so much more than just a webinar or just education. But of course, you do get that as well because you still get over 200 hours of CE. So with all of that, that's essentially the goal, is that my vision and plan is I want dentists to see what's possible. I want you to understand the value that this can provide to your life, because at this point, I work between 1 week a month to once every 2 months now. I make just as much money, if not more, than I did working full-time as an associate, because you can set up systems and operations to allow you to, like I am right now, I live in a completely different city than where I practice. So I'm so fortunate and grateful that I was able to learn this. And so I want to be able to create that community where I can support doctors in that. And I know there's a number who are on this call right now. So if anybody wants to give any feedback or experience as to what Clearly Select has meant for them, please feel free to go ahead and throw that. And I think you'd have to throw it into the Q&A, because I don't know if you guys can all see the Q&A, but there's so many different people who have come to us and said how this has changed the way that they practice dentistry, revitalized their passion, as well as increased their finances and given them control back to not be sitting neck deep in clinical procedures where you can step back and let your staff do it for you. Okay, so with that being said, if it's something you're interested in knowing more about, what I would just say is there's opportunities for you just to fill out an application form. There's no commitment required. It's on our website, clearlyalign.ca, and you would be able to have a conversation to see if this is the right fit for us as well as for you, because we don't accept every applicant. 50% of applicants are not the right fit for what we're trying to accomplish as an educational group. But the cool thing is that right now we do 1/5 of the volume between Canada and the US. We actually do 1/5 the volume of all the cases that are done in Canada in our group. So this is my passion. This is what I want to keep doing for the next 30 years. And my goal is to support you and help provide growth if this is something you're interested in, so you can do the best quality treatment, but also, like I said, be able to take control of your life.